Hello everyone, this is Dr. Pruett again. Today we're going to be talking about seizures. So 5 causes of seizures that I like to consider. Number 1, patients seize that have a seizure disorder. So usually I ask about that. Evaluate for head trauma or hemorrhage. Tumors can cause seizures. Toxins can cause seizures. And lastly, vital signs. We all know vital signs are vital. So that is another cause of seizures that I tend to consider. When you think about seizures, what's going on in the brain is that it's overreaction of cells in the brain, specifically neurons. And when you break it down to a cellular level, cells are basically batteries. They're driven, energy is driven by charged molecules that move across membranes and create an action potential. And the cells and the depolarization in the brain is mainly caused by sodium. So anytime you think of seizures, think of sodium channels and sodium flow that causes depolarization, just like in a battery. So when you break it down and you look at a neuron, there is a nerve cell that sends a signal along an axon. That's where the signal travels, and that's got myelin around it to help it travel faster. And at the end of the synapse here, where the communication happens, there's neurotransmitter release and cellular signal release, and that's where some of your sodium channels are located. And that causes depolarization, and that's the way that cells communicate with each other. And the release of that information and the triggering of those receptors is what triggers cells to do their job, whatever their job is. Maybe their job is to cause a muscle to contract, or maybe the job is to release insulin or make a heartbeat, or whatever it is. That is the way that the body communicates, is those cellular junctions where receptors are activated or inactivated in order to trigger a cell to do its job. So exactly what causes seizures? There's 2 things to think about, and you don't necessarily need to know this, but it's probably important to understand. One is too much sodium. Remember, as the sodium, just like in that battery, as the sodium flows in from the bloodstream, it causes depolarization. Well, if you get too much sodium flowing in for a dysfunctional channel, you're going to get a whole lot of depolarization, which in the brain is going to lead to a seizure. The other thing that might cause it is slow repolarization. So as the cell is activated and then it tries to get back to normal, that gate kind of closes where the sodium comes in. But if the gate is not working and the cell can't reset itself, then you get slow repolarization, which leads to continued stimulation, continued influx of sodium, and that causes a seizure as well. So basically it has to do with defective sodium channels that either polarize the cell too much, or the cell cannot repolarize itself, and again leads to too much stimulation. So our general treatment for seizures is going to be 1, just protecting the airway, making sure they're getting some passive oxygenation while the seizure is going on. And during that time, you can either try to get IV access, which might be difficult because your patient is usually sweaty and clamped down with their arms flexed. If you need to, you can get intramuscular access, because if the seizure is ongoing, you want to make it stop. And this is where you're going to want to give your Versed. So remember that your dose is 1 to 5 milligrams, either IV or IO or IM. You have a lot of different routes to give this. One of my favorite routes in kids is intranasal or intramuscular. And you can do this every 3 to 5 minutes to a maximum of 10 milligrams. Now, as you're trying to evaluate what the potential cause of this seizure might be, make sure you're always checking a blood sugar, because low blood sugar is a whole different line of treatment, and you can answer that question really quickly on scene, determining which route you need to go, whether the seizing patient needs sugar or whether the seizing patient needs Versed. Status epilepticus is a seizure that just doesn't stop. It's technically defined as lasting greater than 5 minutes, or a patient that has 2 seizures back to back without a lucid interval in between. And again, you're going to treat that with benzodiazepine and good airway protection. Benzos, what they do, they don't necessarily act on those sodium channels that we talked about, but they do act on GABA receptors, which is the receptor in the body that tends to slow things down. And so in the brain, this is a very effective way to stop most types of seizures. Not all, but most. So as we're trying to evaluate our 5 causes of seizures, Number one is usually patients who have a known seizure disorder. So if there's anyone around who can provide history, ask if they have had seizures before. I tend to like to ask if this looks like their seizures usually look, or if there's anything different about this one. Usually patients who have a seizure disorder, the most frequent cause of them having breakthrough seizures is the fact that they're not taking their medication, especially in younger children and adolescents. They don't like to take medication, and then they have the consequences of that. So I ask if they've been taking their medication recently. Another thing that can decrease the seizure threshold in a lot of these patients is the following things to think about. Fever will make the brain a little more susceptible to seizures, and we know that very well in children, but it's not just a fact in children, it's all patients that have a seizure disorder. Trauma, any kind of trauma to the brain can decrease the seizure threshold. Stress can do it, and also even something as simple as lack of sleep. So these are questions I tend to ask in patients who have a known seizure disorder, trying to figure out what's going on. Trauma, we mentioned, can cause seizures, not just in patients with seizure disorder, but in any patient. So any kind of closed head injury or head trauma can lead to seizures. This is just the brain showing that it's hyper-excitable. There's been some trauma to those cell signaling cascades can lead to that. These patients will present with a clear history of trauma. Sometimes they'll be vomiting, combative. These are all signs of concussion. Make sure you're considering C-spine injuries in these patients and protecting C-spine if you think it's necessary, if they have midline tenderness or any sort of neurological deficits or complain of pain in their neck. And as always with these patients, make sure you're focusing on the airway and preventing hypoxia. These head injuries can sometimes lead to intracerebral hemorrhages. Usually subdural and epidural are the traumatic ones. There'll be a history of either some sort of blow to the head or a fall where they hit their head. Especially important to consider in elderly and in alcoholic patients. They tend to have head bleeds more often than the general population, especially if they're anticoagulated. There's also a population of people out there who are prone to spontaneous intracerebral hemorrhages, and this can be either due to subarachnoid hemorrhage, a vascular malformation, or potentially a tumor. And these patients that have head bleeds, you'll get a good history from them of either some sort of head trauma or a devastating headache, and then their mental status tends to decline over time, and sometimes you'll see them posture. So when you're seizing patients that are not returning to baseline and are unresponsive and unconscious, almost comatose, sometimes with or without posturing, make sure you're considering head bleeds as a source. The most important things you can do for these patients, you're not going to be able to stop the bleeding on scene, you're not going to be able to reverse any of this, but what you can do is prevent any secondary injury. So if you're suspecting a head bleed, make sure you're doing your best to prevent hypoxia, manage that airway like an expert, keep those oxygen levels up, and keep that blood pressure up as well, because those are the things that you can do on scene to actively decrease the sequelae of brain damage and devastating neurological outcome. If you have a patient that's hypotensive and tachycardic with a bad head injury, realize that this is a 75% mortality. You don't want them to get hypotensive if you can help it, and you want to prevent hypoxia. So what you can do with these patients, we just talked about, control their airway, prevent that hypoxia. If they're seizing, you can give them medication to stop the seizure, but realize if they're unconscious, you're going to even more actively have to manage that airway. So make sure you've got your capnography there, you've got your airway adjuncts ready to go if you need them, and do your best to prevent hypotension. Your job at this point is just to prevent secondary injury and give them the best possible chance at a good neurological recovery. Number 3, in thinking of things that cause seizures, would be brain tumor for me. I always ask about a history of cancer. Sometimes patients will tell you that they've been in remission and they present with a seizure or stroke-like symptoms. I always consider the fact that that tumor might be back. There are certain tumors that like to metastasize to the brain, so patients who have a history of either melanoma or lung cancer or breast cancer or colon cancer, these are cancers that tend to like to metastasize to the brain. And as tumors form, they hijack the blood supply, and they're kind of lazy in the way that they build themselves a blood supply. And these vessels tend to rupture and can cause intracranial bleeding. So ask about a history of cancer and consider this as one of your causes of seizure. You'd still treat it the same way as you would any seizure. You give Benzos, but this will be an important clue in their history that you can look for. Number 4 is we're considering toxic ingestions for causes of seizures. One of the leading causes would be a Tri-Cyclic Antidepressant overdose. Any overdose, remember, you can always call poison control for management or recognition, but this is where being a good investigator on scene and asking about empty pill bottles or recent suicidal ideation is a really good idea. One of the more common TCAs that you're going to see is Flexeril or amitriptyline. Flexeril is commonly prescribed for back pain. Amitriptyline is commonly prescribed for headaches. They're called tricyclics just because of their chemical structure. You can see they have the 3 rings here. And what those will usually manifest as is what we call anticholinergic toxidrome. The way I think about it, this is just the patient's really amped up. So they're going to be altered. They may be in a coma, but they're going to have dilated pupils. They'll be tachycardic, hypertensive. They'll be hot. They'll be dry. Increased serotonin activity, so they might have some myoclonus going on. Those are all going to be clinically apparent and not really life-threatening. The thing that you worry about in any overdose is the cardiac toxicity. And what makes this especially toxic to cardiac cells, but also neurologically, is that it blocks the sodium channels. And so what did we learn about sodium channels? Those are directly linked to seizure activity, but also very important for cardiac activity. And this is what actually kills people. So if you have a suspected TCA overdose, where you're going to look right away is lead AVR, which is one of those leads we tend to ignore, but this is where it's going to be really helpful to you. Because if you look in lead AVR, you're going to see this really tall kind of mountainous R wave in lead AVR, and that might be your clue to a TCA toxicity. There's other clues that we look for in the 12 lead of a TCA overdose patient. You might see, because it is toxic to those sodium channels, which is a big driver of cardiac activity, you're going to see an idioventricular rhythm, maybe no P waves, it may be slow. You're going to have a wide QRS with that tall terminal R wave that we just looked at. If you ever see this, just burn that into your brain so when you see it, you recognize it and you're ready to treat it. Can also draw out the QT. Now, importantly, when you look at that QRS, if your QRS is greater than 100, they're at high risk for seizure. If it's greater than 160, you need to be ready to treat VFib or VTAC. So the way that we prepare to treat a TCA overdose, you're going to base your treatment on what you see. So make sure you get a 12 lead as soon as you can after you get your set of vitals. Determine if they're stable or unstable. If you see that wide QRS, the thing that's going to decrease that QRS is going to be bicarb. So you just keep giving bicarb till that QRS gets more narrow. If that QRS is super wide, the one that's prone to VTAC or VFib, or you see a long QT that's greater than 500, you're going to be having your magnesium ready to ward off torsades, right? Or defibrillate if you need to. If they start to seize with that QRS that's greater than 100, you're still going to treat with benzos, but remember, this is a sodium channel toxicity, and so really what you want to do is you want to be giving bicarb. This is called sodium bicarb, and there's 3 times more sodium in here than actual bicarb. So what you're giving is sodium to overcome that sodium channel blockade. Now, if you have a hypotensive patient who's overdosed, don't forget that you have pressors as well, so you can give epinephrine or Levophed to help bring that blood pressure up. Another toxin that we commonly see that causes seizures is alcohol. These patients, when they withdraw from alcohol, are prone to seizures. They're going to be hypertensive, tachycardic, they may be altered, and they may be seizing. And what happens in alcohol withdrawal is there's a timeline from their last drink because their body has become accustomed to having alcohol on board on a regular basis. It depends on that alcohol to maintain homeostasis. And so the textbooks will tell you that withdrawal with seizures will happen between 1 or 2 days, maybe 48 hours after their last drink. Not all patients read the textbook, so this can happen at any point. I've seen within hours or several hours of their last drink. What happens on a cellular level with alcohol withdrawal is that our bodies like homeostasis, and if you think of this balance here between inhibitory or calming neurotransmitters and excitatory neurotransmitters, there's always a balance. And usually in a healthy body that's not addicted to alcohol, GABA and glutamate are the ones that balance each other out. GABA is the inhibitory or calming neurotransmitter, and glutamate is the excitatory neurotransmitter. When a body that's used to having ethanol around all the time, ethanol kind of takes over for GABA, so GABA isn't produced as much because the ethanol is always there. And eventually the ethanol balances out the glutamate and the patient finds a homeostasis in the setting of having alcohol on board. What happens when you suddenly withdraw the alcohol is that glutamate takes over. And remember, this is your excitatory neurotransmitter, and so everything is in hyperdrive. This is why you're seeing a very anxious patient who's tachycardic, very hypertensive, and potentially seizing, because there's nothing over here. GABA has been deregulated to the point the body doesn't remember how to produce it on the levels it needs to balance out the glutamate, and there's no alcohol there to balance it. So what do? We give benzos, and benzos act on the same receptor that alcohol does, and it balances out the glutamate and brings that body back to homeostasis and stops the seizing. When the patient gets to the point that they're seizing from alcohol withdrawal, this is called delirium tremens. So some other things that you might see in these patients is confusion. They'll be hallucinating. There's something called formication, where this is a word that means the patient can feel or describe a sensation of bugs crawling on their skin or something crawling on them. That's a really disconcerting feeling and very scary, and just heightens that anxiety and agitation. They get autonomic hyperactivity, so that's the hypertension and tachycardia we talked about, and sometimes they can get fever as well. Now realize if your patient is withdrawing from alcohol to this point and having this degree of symptoms with seizures, there's a 30% mortality if it's not treated correctly. So really ask about these things and try to identify these in your alcoholic patients who are trying to quit cold turkey, and get them the treatment that they need as quickly as possible. Another toxin to consider is low sodium. Remember, we talked about seizures are all about sodium channels in the brain and the nerve conduction there. Sodium is also a very important electrolyte in the body in terms of water balance. So if you have a patient who is profoundly dehydrated, or a patient with not enough sodium content in their blood, that's going to cause edema in the brain and can lead to seizures if the levels of sodium in the body get low enough. And this has everything to do with osmosis. If you look at a picture here, this is a patient with normal sodium. The sodium and water balance is normal, and so the brain is not swollen. But if you have too much salt, remember, water follows salt. So if there's not enough salt to pull the water out of the interstitial tissues in the brain, the water is going to be retained in the brain and cause swelling. And then cerebral edema is a bad thing for mental status and can cause seizures as well. Lastly, vital signs can cause seizures. Always important. Make sure you're checking a sugar. Sugar is fuel for the brain. If the brain is not getting enough fuel that it wants, it's going to seize. So as you're getting set up to treat these seizures, make sure you're checking a blood sugar and ready to treat that if you need to, because this patient needs sugar. They don't need benzodiazepines. Hypoxia as well. So the minute you get that hypoxic patient, as the brain is starving for oxygen and cells are starting to die, those sodium channels are going to dysfunction and can potentially lead to a seizure. So the treatment for this, again, would not be benzodiazepines. If you have a hypoxic patient, you need to give them oxygen and manage that airway expertly, like I know that you can. A special patient population to think about when you are approaching a seizing patient would be a pregnant or recently pregnant childbearing age female. Some of them will give you a history of pre-eclampsia. That's defined as a blood pressure greater than 140/90 on 2 occasions during their pregnancy. They may complain of headaches, vision changes, swelling in their legs, or difficulty breathing. But if you have a patient who's pregnant or was recently pregnant and they're seizing, this is eclampsia, and this is an absolute emergency for mom and baby if baby's not delivered yet. So you need to aggressively manage the seizure. First, if they're seizing in front of you, treat the seizure, stop the seizure, give them Versed. But the minute that the seizure stops or you've given that medication, make sure you're at the same time drawing up the magnesium, because this is what's needed as a tocolytic to help, 1, bring that blood pressure down, and 2, stop the seizure. Remember that your patient may not be visibly pregnant, so these seizures from eclampsia can happen up to 12 weeks, which is 3 months after delivery. So ask about any recent baby delivery in your females of childbearing age. Another cause of seizure would be infectious etiology, whether it's bacterial or viral meningitis. These historically have caused seizures as well. Look for rashes, this purpura fulminans. If you see this, this is very indicative. in your altered patient with a headache and a fever, make sure you're taking proper precautions, wear an N95, have gloves and mask and goggles. This is a very contagious disease. If it's bacterial meningitis, you want to make sure you're taking care of yourself first and learn to recognize these signs. Viral meningitis is a little bit more of an indolent course. Headache, stiff neck, fever, all of these things can lead to seizure as well. Just treat them like you normally would treat a seizure and make sure you're addressing the fever as well with either Tylenol or Motrin. Febrile seizures are fairly common in the pediatric population. This happens in young children anywhere from 6 months to 5 years old. 30% of these kids will have a recurrence. Usually it's just in the setting of fever. It doesn't mean they're going to have a seizure disorder for the rest of their life. Usually this is related to a viral illness, whether it's upper respiratory or a different type of virus. Make sure in these seizing kids, we see it enough and we want to believe that everything is just a benign febrile seizure, but make sure you're taking it one step further in these kids and considering non-accidental trauma or even an accidental ingestion in those 2-year-old boys that tend to get into everything. Ask if they've gotten into any medications recently that may be grandma's or mom's or dad's. And make sure you're doing a really good physical exam to assess for bruising or bleeding or any other signs of trauma in these children. Now, in terms of febrile seizure treatment, for Tylenol, remember that your dose is going to be 15 milligrams per kilogram. For Motrin, it'll be 10 milligrams per kilogram. And if they continue to seize after the fever comes down, number 1, consider non-accidental trauma, but number 2, go ahead and treat their seizure with 0.1 to 0.2 mg per kg intranasally, or you can do 0.05 to 0.1 mg per kg IM if you need to a max of 5. So just in quick review, our 5 causes of seizures to consider when you're treating and approaching your seizure patient is just ask them if they have a seizure disorder. Did anything tip them over the edge? Are they taking their medications? If they had fevers recently, are they sleeping okay? Look and evaluate for signs of head trauma or hemorrhage. Ask about history of cancer to evaluate if this could be a tumor. Think about toxic ingestions, and always, always, always make sure you're getting a good set of vital signs and addressing those as you need to. And that's all I have. If you have any questions, please either feel free to reach out to me or to your 7-8 for further discussion. Thanks.